Hello from Minneapolis, and thank you to the organizing committee for the invitation. I'd like to prepare to present a case for mitral valve and valve with balloon-assisted anterior mitral leaflet modification on behalf of the structural team over here at the Minneapolis Heart Institute. Our case is a 72-year-old female. She has a history of rheumatic mitral disease. She had a prior surgery back in 2014. At that time, she received a 25 millimeter Edwards Magna valve with concomitant tricuspid valve repair. She has multiple back surgeries with chronic back pain and sciatica, COPD with restrictive pulmonary disease. She came to our attention as a second opinion. She has known degenerated mitral valve bioprosthesis in the context of heart failure exacerbation, shortness of breath, and NYHA class 3 symptoms. She's been optimally medical treated, and I think just looking at her TE, there's no question that her symptoms are clearly originated from a heavily calcified, degenerated mitral valve with a combination of stenosis as well as regurgitation. You see a mean gradient of 20 millimeters of mercury on her transesophageal echocardiogram at a heart rate of 65 beats per minute with minimal opening. She was originally evaluated combined with our surgical team, and our plan was for a redo surgery given the fact that she had a smaller mitral valve placed at the index surgery. However, when she came in for a right heart cath prior to her surgery, lots of things were discovered that were not previously expected. So she does have severe pulmonary hypertension. You do see almost systemic pulmonary artery pressures and PVR of 9 Wood units. And that was in the context of moderately enlarged right ventricle with globally reduced RV function. And as a result of that, there arose a lot of suspicion of the ability of this patient for post-surgical care and whether that RV would be able to tolerate another redo surgery. So we always get a CT heart morphology to actually better assess the anatomy of the valve, and you can nicely see the mitral annulus in systole and diastole. If you were to go to the mitral valve and valve app that's been developed by one of my partners, Dr. Bapat, you'll nicely see that a 25 millimeter valve actually has a true ID of 24 millimeters, and it is fracturable using true balloons. So if you were to consider a transcatheter mitral valve, you will be looking at a 26 millimeter sapien, and it will nicely show you also the position of the valve so as to make sure that there's no leaflet overhanging and the valve is not ventricularized. The things changed a little bit when you assess for neo-LVOT. So you see a small neo-LVOT less than 100 millimeters squared, and if you were to look for a skirt neo-LVOT, that would bring it about 180. So not exclusive for transcatheter mitral valve and valve, but it will definitely require a leaflet modification. And that's our clinical challenge. So you have a really severely degenerated bioprosthetic mitral valve, almost systemic pulmonary artery pressures with significant right ventricular dysfunction. You have the risks, the inherent risks that come along with redo surgery in this population. She's already having enough comorbidities, and she has a class 3 symptoms. And you have a mitral valve in valve, which is high risk for LVOT obstruction if you were to proceed without leaflet modification. So the decision of the team was to proceed with Batman procedure, and that's pretty much the balloon-assisted laceration of the leaflet and then placement of an S3 through it. This was done in a multidisciplinary team. You can see the imaging from my colleague, Dr. Hamid. We proceeded with a transeptal puncture, balloon septostomy, 14 by 40 millimeters balloon to allow over an Inoue wire to allow for our Agilis catheter to come through. The most important part of this procedure is actually identifying the leaflet that you need to lacerate through, to transverse through, and make sure you transverse at the base. So that's a key component. Otherwise, you will not have enough leaflet removal to establish a safe deployment of your sapien valve. So 3D MPR, again, from my colleague, Dr. Hamid. You can nicely see that we identify the base of that anterior leaflet. Once we're sure, we electrify through it. We use a Asahi Astato wire, quick electrification. We pass into the left ventricle. We proceed with externalization of the wire across the aortic valve. 3/0 by 15 compliant balloon to create a little bigger hole at that base of the anterior leaflet, and you can nicely see it on the TE that we're right at the base of it. Following that, this is a technique. There's a lot of modifications in that technique that have been described. This is our own modification. We'll be publishing soon. Instead of actually going aggressive with ballooning of the leaflet and creating a big tear that would create hemodynamic compromise, we actually do kissing balloons. So we put a second wire through the same hole, and we proceed with two inflations, one next to each other. We believe that this technique, as you can see down on the TE nicely, it will actually allow you to expand the hole more basal instead of across the tip of the leaflet. And as a result, it will still maintain the leaflet intact. So you can nicely see our kissing balloons in the middle picture. Following that, we're bringing a 26 millimeter S3 valve. Across it, slow deployment under rapid pacing. We control the position. You don't want to be very ventricular because otherwise you always run the risk of LVOT obstruction. You don't want to be too much atrial because you will end up having leaflet overhang. And that's the picture right after the valve deployment. You can see a nicely expanded sapien valve. We had already pre-decided, knowing that's a 25 millimeter valve, that we're going to proceed with the balloon post-dilation. We only have some trivial wire-related valvular regurgitation. So you can see our true balloon, 24 millimeter, and expanding the valve more so we can get better valve expansion, more symmetry, reduce the risk for leaflet pinwheeling, and increase the longevity of this valve. And this is our final picture. So you can nicely see no regurgitation, no PVL, no LVOT obstruction. We have a final gradient of 3.7 millimeters of mercury. That's a heart rate of 60 beats per minute. And because we had created the iatrogenic ASD that we had ballooned, we opted to close it with a Gore cardioform device. We got invasive gradients, 2.6 millimeters of mercury from the mitral transvalvular gradient, and a 7.4 peak-to-peak LVOT gradient, so no LVOT obstruction. Patient was discharged home 3 days later. She's doing great, back to her home state and feeling great and enjoying her daily activities. So take-home message, transcatheter mitral valve is a great option for high-risk reduced surgery patients. In a lot of those cases, anterior leaflet modification is required in order to mitigate the risk for LVOT obstruction. Balloon-assisted translocation of the mitral anterior leaflet is a potential therapeutic strategy. Keep in mind, it's a pretty novel technique. There's limited data regarding its use and its success rate. And currently, there's a lot of different small modifications of the procedure being described. Thank you.
So, Costa, thank you for this excellent presentation. Amazing case. Everybody learns a lot, from these cases. So it's a modified Batman technique, and it's. Let me ask, how easy is? Of course, in order to have a successful Batman, you need to target the base of the leaflet, right?
Absolutely, this is correct.
How easy is to get to the base of the valve of the anterior leaflet?
The very honest truth is that you need excellent imaging. It takes a team. It's not a one person. Fluoroscopy has a lot of limitations, and one of the basic limitations of fluoroscopy is that it's two-dimensional. So if you really want to confirm you're at the Batman, you are at the base, you have to take your time, depend on your sonographer, get multiple views. If you're not sure, what we've previously done is rapid pace, so you can actually stop the motion of the leaflet and confirm that you are truly at the base of it. When you cross with your wire, if on imaging you confirm and you're not at the base, you just have to recross. It's one of those procedures that it takes time to. Actually, it's the most crucial step, and once you achieve that, then the rest is kind of moving forward at a higher pace. But it's that make or break moment.
Amazing. So maybe we can have a comment from Dr. Spilias from Miami. Maybe we can go from Minneapolis to Miami. Is it possible to have a comment from Nico? Because 2 years ago he presented the first Batman technique, the original, and maybe you would see that this is a different, is the same animal but a different iteration. So you use kissing balloons, right? You said?
Yeah.
Yes. So, sorry, Nikos. So we use kissing balloons on this one. This is our own modification. There's a few out there. Our rationale behind it, and we have some bench testing behind to show it, is that instead of splitting the leaflets more like base to tip, that's going to create the hemodynamic instability. You increase your base to base split. So that allows you, the whole reason you balloon for is to actually allow for a valve to be, to cross through it. So that's the main target of it. It's not to completely get rid of the leaflet at that step. That's later on. The valve will trap the leaflet. You don't want to remove the anterior leaflet at that step. So everything you do is try and make your hole as big as possible, deliver your valve, while your patient stays as stable as possible.
So it's a safety measure. So Nico.
Exactly.
Yes.
Dear Constantina, great to see you again, even if it's online, and amazing case, amazing technique. And I'm very happy to see the continuous improvement of this technique. Now with the kissing balloon inflation, which provides, as you said, probably a little more controlled, laceration of the leaflet there. And yeah, in the case, I presented a couple of years ago, we had used a 12 millimeter peripheral charger balloon, that the same one that we used to do the septostomy. So we used the same one also for the leaflet. So it was a 12 millimeter balloon, and I created, quite a large hole. And as you said, the goal is to create some space for the sapien valve to get through. Amazing technique. And another thing I noticed, and I wanted to ask you on the TE, on the surgeon's left atrial view, it looks like one of the valve, the mitral valve, the posterior mitral, it was my impression, probably was not like fully aligned with the aortic. So one of the commissures was a little bit close to the LVOT or the aortic valve.
You're absolutely correct. Yeah, you're absolutely correct. So it was placed, what my surgeon called it as the old way of placing the mitral valve. So the commissure was coming more closer to the LVOT than actually having the anterior leaflet covering it, which is why we opted to actually go with Batman instead of Lampoon in this case, because we felt that lacerating like in the middle of the leaflet would not really give you the splay you need necessarily if part of the commissure is coming in there also.
Right. My question was if that alignment, or let's say not perfect alignment, made the procedure more difficult in any way, or not really?
Not really. It's just, it was the tipping point for us to decide whether we're going with Lampoon or Batman, more than that. We still approach it the same way. The main problem with that would have been if it was right in the middle, then you would have two leaflets pretty much affecting, and the technique would not have been efficient. So the fact that it was only a little bit anteriorly directed, but not a lot, allows us to make sure that just by removing the anterior leaflet, you would still have enough space.
Yeah, amazing case and result. Congratulations.
Thank you.
Can I make a comment? Congratulations, excellent case. I want to ask you, you said that the problem is frequent with these valves. I thought that it was more frequent with native valves, when you have MAC and you put a valve there. Do you think that the frequencies has to do with the type of this valve, or the way that it sits, or the small morphology? What's this? How frequent do you think is this problem with the prosthetic valves to obstruct the LVOT?
I think it's a combination of everything. I think it's actually everything originates from the original pathology of what caused the initial valve replacement. So a lot of those times you either have like a rheumatic heart disease, or you'll have some primary MR. The ventricle is not dilated. And as a result of that, you have a very large dilated left atrium with a normal left ventricle. So the moment you'll put a valve in it, like that sits either angular or a little extending into the LVOT, that automatically makes it a problem, which is also what happens with MAC. Like frequently in MAC, you have more mitral stenosis with minimal mitral regurgitation. So surgeons always used to say that MAC protects the ventricle, which is the case. So you'll have a normal ventricle, you'll have a large anterior leaflet that pretty much will interact with your LVOT. I know Nikos also has done it in the past. Do Batman or like lampoons in those cases with like in native leaflets. We always have the concern of how truly protected is your ballooning, and you cannot really control whether it's going to expand towards the aortomitral curtain. In prosthetics valves, you have a ring, and the annular ring is protecting from extending the laceration towards the native tissue. On native tissue valves, we've done it before, but it's always a matter of concern of what the extent actually, how long will your laceration expand, and whether you're going to actually set into issues the aortic valve and the anterior mitral curtain.
Good, excellent. And one final comment, so and a question. So, which are the indications of a Batman or this modified Batman technique as opposed to the classic lampoon technique? When do you use which technique to modify
so
the anterior leaflet?
I think they're both great options. My personal feeling is Batman is a little bit easier compared to lampoon because you only have to lacerate once. You don't have to snare, you don't have to electrify, create flying V's and all this stuff. From our standpoint, decision is how much calcification do you have on the leaflet? One of the issues with lampoon is that if you have a heavily calcified leaflet, most likely the wire will just deviate left and right around of the calcification because you can't really burn through calcium. That's one. Two is where's the leaflet positioning? As we were chatting with Nikos, is it like truly in the middle? Like lampoon works great in splitting the leaflet down the middle. If you don't split the leaflet in the middle of it and you're like a little left or right to it to create a smaller tear, you're not really relieving the leaflet from the LVOT. Last thing is I think data on lampoon are a lot more. There's a lot longer period of data. There is a lot of published success rates, and it's definitely a more established technique. This is a lot newer. We're learning a lot from every case, and I think that it's still a growing field. So both are options. I think you always look into the anterior leaflet. Is my first step is always look at how much calcium does the anterior leaflet have, what's the chance of a successful lampoon, and then take it from there.
Good, excellent. So are there any other comments or questions? Okay, good. So Costa, thank you so much. Thank you for your contribution.
Absolutely. Thank you for the invitation.
Thank you.